Is it on already? I would assume so. Hi, everyone. Hi, everyone. Hello. Hi. I'm sorry to bother everyone with all your conversations, but we're going to start the lecture now. Thank you all for coming to the Russell Sage College's 11th Annual Nutrition Lecture sponsored by CDPHP. I'm glad to have you all here. We've got a crowded room in here. My name is Tessa Ventula, and I work with News Channel 13. My main role is an investigative reporter with the station, among many other roles that I play at the station. But I was asked to do this event by Cameron Rowe, who is in the crowd right over here. Thank you. She emailed me after we did a story together about putting whole milk back in schools 6 or 8 months ago. So it was a big story for me about nutrition, and I really care about this, so I'm very happy to be here today. So that's my role, but I also want to thank Chris Ames, the president of Russell Sage, for being here. A little birdie told me that you had another event coming on, but then it got canceled, so you could be here today. So we appreciate you being here. It's a big event for everyone here, I'm sure. So I want to thank him for being here with us today, and Sage's nutrition department. We'd like to thank everyone for joining us and staying with us. And a special thank you to all of our panelists who are joining us today, who are in the front row with us. So a big round of applause for them as well. I'm going to hear from them later on in the program, so you'll get to see everything that they do when it comes to nutrition. And now I want to ask you very quickly to silence your cell phones. I know we live in a world of technology. I have mine right over here too. I know you can keep it out with you, but make sure to silence it because we don't want to interrupt any of the panelists or anyone that's going to be speaking today. And now it's my favorite part of the time is to introduce Sonia Hauser, the chair of the Russell Sage College Nutrition Department, who will share a few words with us and introduce this year's Preceptor of the Year awardee.
Thank you, Tessa. Welcome everyone to our 11th Annual Nutrition Lecture. We're so happy you could be here today. And of course, we would not be here without the continued support of CDPHP, who sponsors this lecture series. And among other things, sponsors our Sage Thrive initiative. So initiated in 2020, the vision of Sage Thrive embraces a college-wide emphasis on health, well-being, life success, and happiness, supported by creative connections between the curriculum and student life. So thank you again. So at this time, I'd like to switch gears and congratulate our 2023 Dietetic Preceptor of the Year. Our recipient this year is Amy Croft. So please join me on the stage to accept your award, Amy. So Amy is the lead dietitian at St. Peter's Hospital and a longtime mentor to our students. And we just thank you for your dedication to our program and your continued support with our students. Thank you so much. Congratulations. Thank you. Step to the left a little bit. Yes.
All right, so thank you to Sonia and the Preceptor of Year awardee. Now I want to introduce Allison Durand. She is a registered dietitian / nutritionist currently serving as a community wellness advocate for CDPHP. In this role, she oversees food and security partnerships and works closely with many community organizations. Allison attended the University of Nebraska as a pre-medicine undergraduate, but ended up getting a bachelor's degree in nutrition science once she learned how influential nutrition and diet was on everybody's health. She put off medical school applications to complete her dietetic internship in Springfield, Missouri, and has built a fulfilling career in medicine as a registered dietitian. Allison prides herself on simplifying the healthy diet that we once used to know. So that includes everyone and all foods, and is proud to be with us today here at Russell Sage College as one example of the wide range of career paths available to dietitians in healthcare. And now it's my pleasure to call up Allison to share a few words with us.
Just a sec. Good afternoon. I'm so happy to be here as a dietitian among future dietitians, current dietitians, nutrition enthusiasts, etc. I heard same little birdie told me that this year's presentation had record-breaking enrollment and attendance, so that's something that we can all give it up to ourselves for. And I'm very proud to be here representing CDPHP. Quick show of hands, who here has heard of CDPHP? Outstanding. It stands for Capital District Physicians Health Plan. It's a health insurance plan that was founded by physicians, for those who don't know. As a registered dietitian, I know firsthand how important it is to be well-informed about nutrition, especially at a time when so many chronic illnesses such as obesity, diabetes, and cardiovascular disease seem to be attributed to the American diet and lack of access to healthy food. I personally really look forward to hearing more from Dr. Muzaffarian on his perspectives on this, as well as engaging in meaningful conversations afterwards as part of the panel on food as medicine. Nutrition plays a vital role in optimizing learning, promoting physical and mental health, and so much more. At CDPHP, we encourage our members to adopt a healthy lifestyle that fits their life, one that includes whole foods and lots of activity. CDPHP is very proud to sponsor today's lecture and to offer access to our members to registered dietitians in the community and virtually. We also offer a fitness and weight management reimbursement program, health management tools, no-cost virtual wellness classes, and much more. I'm available at the end of the presentation should you want an earful on that. For nearly 40 years, CDPHP, again, a physician-founded and guided health plan, has teamed up with organizations like Russell Sage to educate the public on numerous health topics, and we're very committed to continuing that effort. And I thank you for attending, and I hope you enjoy the program. Thank you.
All right, Allison, thank you. And it is now my pleasure to introduce our speaker today, Dariush Muzaffarian. Amongst his many achievements here, Dr. Muzaffarian is the Dean for Policy at the John Myear Professor of Nutrition at the Freeman School of Nutrition Science and Policy at Tufts University. Dr. Muzaffarian's work aims to create the science and translation for a food system that is nutritious, equitable, and sustainable. He has authored more than 500 scientific publications on dietary priorities for obesity, diabetes, and cardiovascular diseases as well, and on evidence-based policy approaches and innovations to reduce diet-related diseases in the US and globally. He has served in numerous advisory roles and his work has been featured in a wide array of media outlets. Thomson Reuters has named him one of the world's most influential scientific minds. Big honor right there. And now, let's turn it over to Dr. Muzaffarian.
Thank you so much. It's a pleasure to be here with you. I apologize, regret that I couldn't come in person. I know you have such a beautiful campus there, and it would have been lovely to be in person. I was asked to speak for the next 45 minutes or so on the White House conference. This was a conference that probably, I can't see you to raise your hands, but I'm guessing many of you in the room haven't heard of. And we should all know about and follow what's going to happen from it. So we're going to tell you about this incredible conference that happened in September. But first, I'm often asked, how I'm a cardiologist. How did a cardiologist get so interested in food? How did I become a dean at a major graduate school of nutrition? And I think, my short answer, a little bit tongue-in-cheek, but also true, is how come every cardiologist isn't interested in nutrition and passionate about nutrition? Because this really is what's facing us today. Nutrition really is what's facing us today as the top cause of poor health. And what this chart shows, this is a paper we contributed to, the chart shows the causes of death in any one year in the United States. And the numbers of deaths are down here at the bottom on the axis, 100,000, 200,000, 300,000, and so on. And the risk factors for those deaths are shown. At the top cause of overall death in the United States is poor diet, exceeding tobacco, air pollution, low physical activity, exceeding every other cause of death. And so by these estimates, approximately 500,000 Americans die every year. 50,000 Americans die every month directly due to poor diet. And this is because we have a failing grade on nutrition. There's a score called the Healthy Eating Index, which gives a score of how closely a person is following the dietary guidelines. It goes from 0 to 100. The average score in the United States on the Healthy Eating Index is 58 out of 100. And for any of you there in the audience who are students, if you got a 58 out of 100 on your final, you'd be pretty bummed out. That's the score of America's diet. And this graph here shows, the score by age, and the best diets are in the youngest kids and in the oldest adults, and the worst diets are in our youth, especially ages 9 to 18, which is really terrible that our kids are eating worse. And while, of course, there are disparities in nutrition by race and ethnicity and income, there's not a single age, race, ethnicity, sex, or income group in the United States that has an average score above 65. So really, we are failing nutrition in this country. And this shows in poor diet. It's shocking how sick we are. I mean, these numbers should absolutely floor you. More American adults are sick than are healthy. Being healthy is now the exception. 1 in 2 adults in the United States have diabetes or prediabetes. 1 in 2 have a lifetime risk of cancer. 3 in 4 have overweight or obesity. And if you put that together with blood pressure and blood cholesterol levels, only 1 in 15 adults in the United States are metabolically healthy. 14 out of 15 people are walking around feeling sick, and most of them don't even realize it. And all of this is new. This is not the case 30 or 40 years ago. In my lifetime, this has happened. So this is a very, very new phenomenon, and it's actually happening not only in the US, across the world. And the really tragic thing is this is happening at younger and younger ages. And so today, among American teenagers, 1 in 4 have prediabetes, 1 in 4 have overweight or obesity, and 1 in 6 have fatty liver disease. Now, in addition to poor nutrition, we have a lot of food insecurity in the country. Food insecurity means at any time over a year, not having secure access to enough food to feed yourself or your family. This is different than hunger, long-term hunger, where people are, losing weight and have, distended bellies and emaciated arms, like you see in cases of famine. But this is true food insecurity that's a major mental and economic challenge for millions of Americans. 1 in 10 households in the US experience food insecurity at least one time during 2020. And this is in every state, in rural and urban areas, Republicans, Democrats. There's no segment of society that's spared from food insecurity. And here, like with poor nutrition, inequities are pronounced. And so for households that are, of course, low income, their food insecurity is much higher. For households led by single mothers, their food insecurity is much higher. For households led by Black or Hispanic adults, food insecurity is much higher. And COVID-19 has put an exclamation point on this by showing us both that there's inequities by race and ethnicity in who gets COVID, but also there's severe differences in risk depending on whether or not a person has a diet-related disease. The top risk factors for poor outcomes from COVID-19 are obesity, diabetes, and hypertension. And we did a paper with one of my doctoral students, and we estimated 64% of COVID-19 hospitalizations in this country might have been prevented if we had a metabolically healthy population. If you have obesity, diabetes, and hypertension, if you have all three, you have an 8-fold higher risk of a poor outcome with COVID-19. Why is that? It's because COVID-19 is not just a pulmonary virus, it's a vascular virus affecting the blood vessels, and it's an inflammatory virus causing systemic inflammation. Obesity, diabetes, and hypertension, what they have in common is they're diet-related diseases that have a common underlying pathophysiology of vascular dysfunction and systemic inflammation. And so you're taking a virus that attacks the blood vessels and causes inflammation, and you're putting it into a population that has diet-related diseases with vascular dysfunction and inflammation. It's like pouring gasoline on a smoldering fire. And so this put an exclamation point on how sick we are as a nation. Now, beyond the impacts on poor nutrition, diet-related diseases, food insecurity, there are crushing economic costs to this. And this is actually very important because this is what leads to policy change. If you talk about human suffering, if you talk about disparities, you're not going to get that many people to actually change business as usual. But if you start talking about dollars, people start to pay attention. So this is really important. Since 1970, healthcare spending has risen from $1 in $20 in the federal budget to nearly $1 in $3 in the federal budget. we talk about a lot of things about why there is new partisan disagreement and acrimony and budget arguments in Congress today. But we don't talk about this. Healthcare spending is suffocating, is drowning out every other spending priority. It's gone from 5% to 30% of the budget. There's no money left to do anything else. And so rising healthcare spending is a huge, huge burden on the federal budget. It's also a huge burden on our entire economy. In 2020, healthcare spending was 20% of gross domestic product, meaning 1 out of every $5 spent by every single person and every single business in our economy was spent on healthcare. That's not okay. And 80% of this is spent on preventable chronic diseases. Many of these are diet related. And if you put together all of the health costs directly due to poor diet, our food system is estimated to cause $1 trillion, over $1 trillion in economic losses every year. And this is the estimate from this paper. I encourage people to look at this. This is an analysis by McKinsey, supported by the Rockefeller Foundation. We spend about $1 trillion on food. In other words, the whole food sector, from farms all the way to restaurants and supermarkets, generates about $1 trillion for economy. And at the same time, we lose $1.1 trillion due to lost human health. So every dollar we spend on food, we lose another dollar in poor health. This also strains military readiness, and this is very important to get policymakers and people of all backgrounds to care about poor nutrition. This isn't just about healthcare spending. This is also about our military. 8 in 10 young Americans today don't qualify for military service, and the top medical reason for this is excess weight. And there's a terrific group called Mission Readiness who's put out a series of reports. This is a recent one called Unhealthy and Unprepared, who are making the very strong statement that poor nutrition and diet-related diseases are national security threats because we do not have enough Americans to have a fit military. And lastly, this is also, the challenges we have are also potentially positives. There's real potential here to unlock business innovation. 1 in 10 jobs in our country are directly supported by food and agriculture. And as I mentioned, the food and agriculture sector creates about $1 trillion of economic output. And if we want to think about improving the lives of people from Black or Hispanic backgrounds, the number one source of small businesses and the number one source of small jobs in racial and ethnic minority communities are in the food sector. Food trucks, farms, retail stores, and so on. So there's a real potential here to unlock business innovation. So if you put all this together, if you put together the health impacts, the equity impacts, the food security impacts, the job impacts, the impacts on military readiness. And I haven't even talked about sustainability. I don't have time in my talk to talk about water use and land use and climate change and all the other things due to food. This is actually the biggest challenge and biggest opportunity facing our nation and the world. We have to figure out how to feed ourselves. This is the single biggest challenge in the world. So how did we get here? This is mostly new. I emphasized that at the beginning. This is not something that slowly came on over 200 or 300 years. This is a rapid onslaught of diet-related diseases, particularly obesity and diabetes, in just the last 30 or 40 years. We got here because our modern food system today is a 20th century legacy. It was built to meet 20th century goals. What do I mean by that? There were 2 major goals in the 20th century around nutrition. The first was to get vitamins to people. Vitamins were discovered in the 20th century. They weren't even known, in the 1800s. So vitamins were discovered in the 20th century, and they were first isolated and synthesized in the 1930s. That's less than 100 years ago. And so all of these diet-related vitamin deficiencies like pellagra and scurvy and rickets and beriberi, these were common around the world. There are some reports that pellagra, which is caused by niacin deficiency, 80% of Black children in New York City in the 1930s had pellagra. These were very common diseases. And so it was very important to think about how to get vitamins to the population because that was the science of the time. The second big thing that happened in the 20th century was World War II. And we've seen the disruptions to the food supply from the Russia attack in Ukraine and the disruptions to wheat and what that's caused to food prices and other things. What we're seeing today is nothing compared to what happened in World War II. During World War II, 28 million people died of famine. 28 million people died of famine. So think about these 2 incredible pieces of history in the last century. Incredible concern about vitamin deficiencies, incredible concern about getting enough food, and famine. And then the third thing that happened in the last century was a population explosion. More people were born in the last century than in all of human history combined. There was about 1.6 billion people in 1900. There was about 2 billion people in 1927. There was about 3 billion people in 1960. And by 2000, there was 6 billion people. The population of the world doubled and doubled again in 1900. And there were books written, like The Population Bomb by the Ehrlichs from Stanford, saying that we were going to have hundreds of millions of people starve by the time we reached the year 2000. And so what happened? We dramatically changed the food supply, starting in the 1940s and 1950s and accelerating in the 1970s. We dramatically changed the food supply. Agriculturally, that was the Green Revolution, which was supported by the Rockefeller Foundation, the governments of the United States, Mexico, India, Pakistan, many other governments. We changed the way we produce crops to focus on a few specific crops that are grown in a certain way, wheat, rice, and corn, and grow them with pesticides and fertilizers. And look what happened. This chart here shows corn production per acre in the United States from 1866 to 2012. You can see from 1860 to 1960, for 100 years, there was no increase in corn yields in the United States. And then look what happened after 1950, 1960, this incredible rise, an 8-fold rise, an 800% rise in corn yields. This saved 1 billion people from starving. And so, when you look at the policies and the actions that took place in the last century, they were around these priorities. Let's get vitamins to people and let's get calories to people. And so, for example, Franklin Delano Roosevelt in 1941 brought the government together to ensure the population was ready for war. He called for a conference, which was called the National Nutrition Conference for Defense. And its focus was vitamins. How do we get enough vitamins to people? So it led to new standards and expansion for vitamin-enriched flour. It led to the creation of the RDAs. The RDAs are those facts you see on the back of the nutrition panels, the percentage requirements for nutrients. That came out of this conference. And it led to the first dietary guidelines that are based on the RDAs. And so this major national action in 1941 dramatically improved the vitamin supply for the US population. Now, in the 1960s, the next thing that was recognized was led by Jean Mayer, who founded our school. I'm the Jean Mayer professor at Tufts. And Jean Mayer, together with President Nixon and Senators George McGovern and Bob Dole, a Democrat and a Republican, put together the 1969 White House Conference on Food, Nutrition, and Health to address hunger in America. And this led to tremendous policy actions. It led to major expansion of the food stamp program, major expansion of the school lunch program, creation of the WIC program. This program gives supplemental nutrition to women who are pregnant or to babies up until a young age. 1 in 2 babies born in the United States are on the WIC program. And it's recently been in the news. You might have heard about this because of shortages of infant formula. The WIC program is very important. It led to creation of the school breakfast program, which was actually modeled off of a program started by the Black Panthers. It led to creation ultimately of the Nutrition Facts Panel and of the modern process for setting dietary guidelines. So this was very important. So these 2 conferences of the last century are focused on vitamins and calories, and they were successful. When we look at the food system today, many people in the room who are young and care about food, probably look at industrial farming or look at processed foods and get so upset and say, hey, how do we have a food system like this? There are, of course, profits to be made. And one of the reasons we have a food system like this is for business to make profits. But I think what's really important to understand is the food system we have today was purposefully created based on the best science and policy of the 20th century to deal with the huge problems of the last century, which was vitamins and calories. And so when you see these fields of wheat or rice, or when you walk down the cereal aisle and you see these vitamin fortified, starchy, inexpensive cereals, you are seeing a very purposeful creation of a food system to deal with 20th century problems. And we dealt with those problems. Hunger has dramatically decreased around the world. Vitamin deficiency diseases have dramatically decreased around the world. These policies were very effective to meet the goals they intended to meet. But what they didn't anticipate is these radical changes to our food system, starting really in the 1960s, 1970s, led to a new epidemic of chronic diet-related diseases, and that's where we are today. So, when I learned this history over the last 10 years, I said, it's been, at the time, around 50 years since the last White House conference in 1969. And so isn't it time for the White House to really call the country together and say, look, we have new problems. We have new problems compared to 1969. Let's think about how to solve them as a nation. And so we brought together an independent task force that was co-chaired by Chef Jose Andres, the founder of World Central Kitchen, Ambassador Earthren Cousin, a former director of the World Food Program, Senator Bill Frist, who is a cardiovascular surgeon and former Republican Senate Majority Leader, and Secretary Dan Glickman, former Secretary of Agriculture, to really put together recommendations to the White House to hold this conference, and then to provide recommendations from the country, bipartisan or nonpartisan recommendations of what the conference should focus on. And a major champion for this conference was also Congressman Jim McGovern in Massachusetts, who really led the effort in the House, together with the late Jackie Walorski, and then also Senators Cory Booker and Mike Braun in Indiana and New Jersey were also champions in the Senate. And so the White House, saw the problems, and to their great credit, President Biden decided to hold this conference, and he put in charge the Domestic Policy Council, led by Ambassador Susan Rice, who's incredibly smart and incredibly talented, of how we can figure out how to fix the problems we face today. And so we put out a report before the conference, and I welcome everyone to come and look at the report, which puts together input from people around the country. We held many conferences, many listening sessions, looked at many reports, and we put out a report of how we should actually fix food to end hunger, advance nutrition, and improve health in the United States. And so I really encourage people to look at this. We really centered our report and our recommendations on evidence, on what's actionable, and on the perspectives of individuals with diverse lived experience in hunger, poor nutrition, and health. And so these are, kind of a summary of some of our recommendations. There's no single silver bullet that's going to fix the food system today, but there's also not 1,000 things we need to do. We need to do about 30 or 40 things that are all sensible and practical and evidence-based. And these things span improving and strengthening the government nutrition programs, leveraging the power of health and education, leveraging the power of our healthcare systems to deliver food and nutrition to people, advancing science and research, using business innovation, and actually having national coordination. And then on September 28th of last year, President Biden opened the White House Conference on Hunger, Nutrition, and Health. There were bipartisan leaders there. There were secretaries from USDA and HHS there, many others there, individuals with lived experience there. And what was most important wasn't the day. The conference was great, but what was most important was the national strategy. Over the previous year, the White House had worked really hard across all of the major federal agencies and also speaking with Congress to put out a national strategy. And there were 5 pillars to the national strategy: how to improve food access and affordability, how to integrate nutrition and health, how to empower consumers to make healthier choices, how to support physical activity as a key complement to good nutrition, and how to enhance research. And all of the agencies in the White House are now working very hard to implement this plan. It's a plan to over the next 8 years. So things that the government can do through 2030. Why are policies so important? I'm going to show you this scientific paper published by a former postdoctoral fellow of mine together. Why are policies so important? Policies are so important because it has a big, big impact. What this chart shows is the percentage of food consumed in the United States by US children. This is nationally representative data from different sources. And what it shows is the percentage of food that's consumed that's of poor nutritional quality. So higher is worse. You don't want to be higher on this graph. And we look at the food sources: restaurants, grocery stores, schools, and all other sources, which includes like entertainment venues and food banks and food trucks, other things. And so this is the food that's actually consumed from these sources, not what's available, not what's on the menu in the restaurant or what's available on the shelf, but what people are actually buying and eating. What you can see first is that restaurants are really bad. About 80% of all food in the United States consumed by kids from restaurants is of poor nutritional quality, and it hasn't really gotten much better over the last 20 years. So that's the red line. Second, look at the orange line, grocery stores. The food consumed from grocery stores is actually getting a little bit better. It's not a huge improvement, but about 53% was of poor nutritional quality 20 years ago. And based on the most recent data now, about 45% is of poor nutritional quality. So that's an improvement. On the other hand, the purple, the other sources, it's gotten worse, and it's kind of offset some of that improvement in the grocery stores. And so the red line, the purple line, and the yellow line is about 90% of calories for kids. It's where kids get most of their food. And what you see is all the efforts that we've done around education and dietary guidelines and trying to promote industry to reformulate their foods. All of that effort is what you see in the red line, the purple line, and the yellow line. Now, what happened with the green line? The green line is schools. You can see from 2003 to 2010, about 55 to 60% of all meals consumed by US children in schools was of poor nutritional quality. More than half. That's terrible, right? That's terrible. Schools were not a very healthy place to eat. But look what happened after 2010. There's a dramatic improvement in the nutritional quality of school meals, so that by 2017-18, which is the most recent national data that were available, only 25% of school meals are now of poor nutritional quality. If you look at that from a pessimistic point of view, you'd say, 1 in 4 meals in schools are still really bad. That's true. And there's more room to go and it should be improved. On the other hand, schools today are the healthiest place where kids on average are eating. So that's where kids are getting their healthiest meals of the day, is in school. So what happened in 2010? What happened in 2010 was the Healthy Hunger Free Kids Act was passed by Congress with support of the First Lady Michelle Obama, with support of Mission Readiness, with support of people in the House and the Senate. A law was passed, a single law was passed, improving the nutritional standards of school meals. And so you can see the power of a single policy, a single law. It improved the nutrition for millions and millions of American children in just a few years, compared to everything else we're doing has barely budged restaurants and grocery stores. So what is the national strategy? As I said, there's multiple pillars. I'm just going to quickly highlight what I think is, one of the areas that's very exciting, which is around healthcare. How do we actually get doctors and healthcare systems to start improving health through nutrition? And this is happening. And so all these things are in the national strategy that was put out in September, to have these food as medicine programs in Medicare and Medicaid, which ensures the vast majority of Americans, including things like medically tailored meals, produce prescriptions, registered dietitian counseling for obesity, and so on. And I'll tell you more. I think I have a couple slides on what these things are for medically tailored meals and produce prescriptions. To have produce prescriptions in the Indian Health Service and in the VA, to have better nutrition education for doctors, to screen for food security throughout the healthcare system, to create a stronger and more diverse registered dietitian workforce, and many other actions. So this is real concrete actions to get food and nutrition into healthcare. Now, what I want to point out is what I think is exciting about some of these innovations is this isn't just about calories, and this isn't just about getting food to people and reducing food insecurity. That's really was the focus of the 1969 conference. This conference does want to reduce hunger and reduce food insecurity, but also advance nutrition security. And nutrition security is a relatively new concept, and this should be added to the concept of food security. So not just getting enough calories, but also getting nourishing food. And so I think this is really important. And the USDA Secretary, Tom Vilsack, has really been a champion for nutrition security. And even in his confirmation hearing, he talked about nutrition insecurity. And we have to do more to ensure access to the nutritious foods that can protect and promote health. That is not a common message from USDA agricultural secretaries, who traditionally have been there to promote the interests of businesses. Secretary Vilsack is a champion for improving nutrition. He should really be acknowledged for that. So what is food as medicine? Again, this is just one example of what's in the national strategy. Food as medicine is getting doctors to write prescriptions that go to patients to get them food that's paid for by the healthcare system. And it sounds crazy, but it's actually happening in real time. And so this is a paper we wrote, which sort of summarizes food as medicine as kind of a pyramid. At the top of the pyramid are interventions that are for the sickest, smallest number of patients who are severely ill with end-stage renal disease, with heart failure, with AIDS, with cancer, with poorly controlled diabetes. For these patients, they actually can get fully prepared, medically tailored meals, usually 10 meals per week, lunch and dinner for Monday through Friday, that are fully prepared. And research has shown that giving patients food when they're sick, when they're malnourished, keeps them out of the hospital, keeps them out of the emergency room. For patients that are a little bit further down the pyramid that aren't quite as sick and can shop and cook at home, you can give them a fully medically tailored grocery box or a produce prescription program where you write a prescription and they get fruits and vegetables fully or partially paid for by their insurance. These programs also work. And there's further things down the pyramid, like, for example, using SNAP and WIC and school meals and other population level programs. And again, these things are happening. These things are happening right now. And we published an analysis earlier modeling what would happen if we actually rolled these programs out. And we first looked at medically tailored meals. We found that about 6 million Americans are sick enough to need medically tailored meals. And we looked at all the data and we said, on average, the cost of these meals is about $9 per meal. And if you rolled these out, you not only would improve health, you'd prevent 1.6 million hospitalizations, you'd actually save money. Even accounting for the cost of the program, you'd save $14 billion in 1 year if all 6 million Americans got this program. And at 10 years, you'd save $185 billion. So this is a no-brainer. We should be giving these people who are eligible and qualified, food, have it paid for, and this will save the healthcare system money. Produce prescriptions probably won't save money, but they'll be cost effective. They'll be just as cost effective as blood pressure lowering drugs or cholesterol lowering drugs or cancer screening or all the other things we do in healthcare, but they're doing it through the power of food. And we looked at this and found that these things work. They increase fruit and vegetable intake, they reduce body mass index, and they reduce hemoglobin A1C, which is a marker of blood sugar control. Now, the White House, importantly, in their strategy, didn't just call for actions that the federal government can do. They called for whole of society actions. They called on the states, health payers, health professional schools, hospitals, state, local, and territory governments to also take part in this national strategy. I think that's really, really important. And so, for example, they called on the states, all the states, to leverage all their abilities within their state authorities to expand coverage of food as medicine interventions. And they called on medical schools and residency programs and fellowships to start to integrate nutrition education into doctors' training. And these things are starting to happen. So this is a chart showing the different states that have applied for and had approved what are called Medicaid Section 1115 waivers, which lets them potentially buy for and pay for food. And they're divided into categories, and what each bar shows is when the waiver was submitted and when it was approved. And so all of these are now active approved waivers. Category 1 waivers didn't have very much in them about nutrition. Category 2 waivers in yellow included nutrition education, and Category 3 waivers in green include not only nutrition education, but other food-based interventions like medically tailored meals or produce prescription programs. So today in Massachusetts, North Carolina, California, Delaware, New Jersey, New Mexico, New York, Oregon, and Washington, all these states are testing and implementing programs like I just mentioned. Really exciting progress. And also the Accreditation Council for Graduate Medical Education, which accredits all medical schools, residencies, and fellowships, just held a meeting in March on how they're going to make sure that all medical schools and residency programs and fellowships advance medical education. And so they are also starting to take action. There are other things going on in the private sector. So Kaiser Permanente, the largest HMO in the country, has committed $50 million to expand their food as medicine program. The Rockefeller Foundation and the American Heart Association have committed to raise $250 million to advance food as medicine research. The American Academy of Pediatrics and the American College of Lifestyle Medicine have committed to training doctors around nutrition. And Instacart Health, which is an online grocer, has committed to new programs and partnerships to improve nutrition, healthier choices, and health outcomes. And so that's just one part of the national strategy around food as medicine. There are many other parts that I don't have a lot of time to go into. There also is information there about advancing nutrition science. This is a cornerstone to everything we need to do. We didn't understand all the science of food and nutrition in 1990 and 2000. We were recommending low-fat diets, which turned out to be a mistake. Now we know a lot more, but we still have so much left to learn. And so we really have to invest in nutrition science. And we've called for a new National Institute of Nutrition. There is no Institute of Nutrition in America. There should be. This is the top cause of poor health. It's a major cause of health disparities. It's driving up healthcare spending. We need a National Institute of Nutrition to really push forward the science and make sure we know all the science we need. And lastly, we need to coordinate all of this. And a report came out from the Government Accountability Office, which is the watchdog that audits the federal government. And they came out with a report in 2021 on diet-related diseases. And these are their conclusions. Chronic diet-related health conditions are costly, deadly, and preventable. They basically summarized my talk. And they also identified there are 200 different federal efforts spread across 21 agencies that are trying to fix this. 200 different efforts. These fragmented efforts, they said, are keeping the government from meeting its goals. And they called for a federal strategy for diet-related efforts to provide sustained leadership and cost-effective outcomes for reducing diet-related chronic health conditions. And they called on Congress to do something about this. And so the White House conference is a great start, and the national strategy is a great start. But we believe there should also be someone in the White House at the cabinet level that is coordinating federal food policy. And so we've called on the White House to consider an office of the National Director of Food and Nutrition. We have an office of the National Director of Intelligence that coordinates all of the intelligence in this country. We need an office of the National Director of Food and Nutrition as our food is killing more Americans than any other cause right now in our country. One thing that wasn't in the national strategy that I wish was more, there wasn't really a plan as much as I would have liked to seen to catalyze the private sector. We are now catalyzing the private sector around green energy and cars and electric vehicles and other clean energy. We're now catalyzing the private sector through government around silicon chips and manufacturing. We've done it in the past around railroads and cars. The government's often identified key sectors and used tax policy and other policy to sort of move the whole private sector in a certain direction. It's time to do that for food. Customers are demanding it, investors are demanding it, many companies are trying to make healthier products. We need the government to catalyze this and leverage this and move this forward. And there's lots of ways to do this through investment and tax policy and other things. So at Tufts, we're continuing to try to inform and advocate for these changes. If the national strategy is just a PDF that's online and nothing happens, it would be a massive shame. And so looking back to the 1941 conference and looking back to the 1969 conference, those conferences achieved major change. We hope that this 2022 conference will also achieve major change. And so we're focused specifically on food as medicine, on advancing nutrition security, and on advancing nutrition research. And we've put together over 100 organizations, which includes clinical organizations, academic organizations, nonprofits, and food companies and pharmaceutical companies that are in support of this effort. And so people ask me, are the food companies opposed or the pharmaceutical industry opposed? Not all of them. There are many who see the writing on the wall and know that it's time to fix food. And so I've really appreciated the time to be able to share with you sort of my perspective on the White House conference and where we're going. I'm optimistic, but I'm also not looking at the world through rose-colored glasses. We have to all work together. We have to keep up the pressure on our elected leaders. We have to keep up the pressure on business to really move forward this national strategy. And if we do, by 2030, we can have substantially improved many of the problems that we see today. So thank you so much, and happy to answer any questions.
Does anyone have a question for Dr. Musafarian? All right,
Thank you
if there's
very
a
much.
question, you could
Yep.
use a microphone, I guess I could hear it.
Sure thing. Hi, I'm Ellie Wilson. I'm an alumni here from SAGE, and we met at the conference in Washington in November. My question is, one of the things that I have observed over my years in different parts of nutrition is the struggle to ensure physicians understand the opportunity and collaboration, opportunity, even, improved productivity, reduce fatigue, etc. How do we, and I'm thrilled to see the slides you just put up, but how do we ensure we can really help physicians understand how they can connect to and improve care by referring to dietitians?
Yeah, so first, I want to say as a physician, I know that we have a very small relative impact on health compared to everything else that goes on in society. And so we have to also fix all those other things because you see your doctor once or twice a year. You have to have a society that's also promoting nutrition. That being said, physicians have a critical role, and we have to fix that. So I think it's pretty clear to me that if we just well, and second, so that's first. So second, there's been many surveys and studies of physicians and how they feel about nutrition, and they're all show the same thing. 70 to 80% of doctors want to know more about nutrition. They want to learn more about it in their training. They don't feel qualified, and they're asking for the training. So doctors are actually asking for the training. And there have also been there have been several controlled trials showing that if you give physicians interactive education around nutrition, culinary medicine, other lifestyle medicine, interactive education, it improves their knowledge, it improves their use of nutrition tools, it improves their referrals, and so on. So we know how to do it. So if we try to go medical school by medical school or residency by residency and do this, it'll take us 50 years. It's not going to work. And so the way to do it is to change two things. We have to change the accreditation guidelines. Every academic institution has to be accredited. Your college has to be accredited, and so medical schools have to be accredited. So we have to change the accreditation guidelines, and then we have to change the tests that doctors take, whether it's their boards when they graduate medical school or their boards when they finish their residencies. We have to change those tests. If we change those two things, nutrition education will change overnight. And so I'm encouraged by this effort by the ACGME and the AAMC and AAMOC to come together and talk about nutrition education. They haven't yet committed to making it mandatory and making it a mandatory part of accreditation. We should all be pushing and prodding and promoting them to make it mandatory.
Does anyone else have a question? Up in the front here.
Thank you, doctor. My name is Cara. I'm a registered dietitian, Russell Sage College alumni, and I'm actually attending Tufts in the fall, so I was really excited to come see you. I guess I have a comment. I really love this presentation, and in your recommendations, I really like how you highlighted the need for diversity in the nutrition field. As we know, COVID-19 disproportionately affected BIPOC communities, and it just so happens that diet-related chronic diseases also disproportionately affect BIPOC communities. And I've read a couple of studies that have supported just the lack of diversity in the field definitely correlates with those diet-related chronic diseases in America specifically. So I just wanted to say I was really happy that you highlighted that. As a Black dietitian, that really means a lot to me.
Terrific, and I have some thoughts and comments on that. But first, what program are you entering?
The online program, the Sustainable Food Systems and Agriculture program.
Great, terrific. Well, yeah, I should put out a call out that we're a graduate school. The Friedman School is a graduate school giving Masters of Science and PhD degrees. We don't train RDs, although we have a joint training program with the hospital. But we're not a RD program. We're giving master's degrees and PhDs in the areas that I talked about: agriculture, food and environment, biochemical and molecular nutrition, community interventions and behavior change, data sciences and epidemiology, and many others. And so any undergraduates who are interested in getting a master's degree or PhD should definitely look at our school, and really delighted that you're joining the school as well. So it's absolutely true that both in the RD workforce, the dietitian workforce, and the scientist workforce, that BIPOC individuals are severely underrepresented, and that's why we need funding and support within the federal government policies to change that. And in the national strategy, it does actually say that the Biden administration will commit funds to increasing training of a more diverse RDN workforce. And there's actually, if I recall, specific dollar amounts on that. And then secondly, the NIH has created a new Office of Nutrition Research within the NIH Office of the Director one of the goals of which is to help train and provide training grants for a more diverse nutrition science workforce. That Office of Nutrition Research doesn't have a budget. It's been created and doesn't have a budget. And in the president's budget this year, the president asked for $121 million for that office, which, if funded, will give it significant resources to expand training. And so we're working really hard, and everybody should be telling the Senate and the House that we need to fund the Office of Nutrition Research. So I think you're totally right. It's a big problem. And what we need to do is convince those folks that fund these programs to invest in this.
All right, Cara, thank you. I believe we have time for one more question.
Beth Dollinger, I'm a retired orthopedic surgeon who happens to think nutrition's really important and got certified in culinary medicine. Having looked at curriculums across the country, there is very little, and while medical schools are talking about it, they're not really bringing it in. So I'm not sure where in these curriculums it's going to be integrated. And is there a standard curriculum that you think is going to work better than another curriculum, and where do you see it being integrated?
Yeah.
Secondly, how do you see talking to surgeons who think that the only thing they need to do is go to the operating room and then make rounds and go home, that nutrition is important? And third, you mentioned something about food companies buying into this. You go into a grocery store and food companies pay for the stuff that's not good for you at eye level. So how do we fix that problem? And I realize I just asked you a whole lecture's worth of material, but go for it.
Well, as I said, the way to change the curricula is to change the accreditation requirements. And the accreditation requirements are very broad and say you have to have an effective program, and then the programs figure it out. And there isn't enough experience to know exactly what works best. But I think that, as I mentioned, what seems to work best is programs that aren't just coursework, but also have some culinary or agricultural or other experience, so that doctors don't just kind of hear about nutrition, but they're actually touching and learning about food. And so the way to move that forward, again, is through the accreditation system and through the tests. I wouldn't be too quick to dismiss surgeons' interest in nutrition. We're doing a project now with Tufts Medical Center across the street, and we're trying to integrate screening for food insecurity and screening for nutrition insecurity into the EPIC system, the electronic health record. And when we approached the hospital and said which department wants to partner with us to pilot this, the Department of Surgery stepped up first and said, we're very interested in wound healing and post-op complications. We know poor nutrition is the biggest determinant of that. And so we'd love to work with you to improve the nutrition of our patients. So doctors get it. Doctors get it. They just don't have the skills and abilities to do this. And lastly, I think we're really overemphasizing doctors' education. If we don't have produce prescriptions and medically tailored meals that are funded, doctors could know what to do, and there's no intervention. So I think those interventions are really important. And secondly, we have to fix, as you said, the food in the grocery stores, the food in the restaurants. We have to continue to improve food in schools, and so on. I've thought a lot about your last question, which is business. And I have mixed, kinds of reactions to the private sector. There are certainly products in the private sector that just need to go away, like Skittles and soda. With all due respect to Skittles and soda, we don't need those products. It doesn't mean we shouldn't have dark chocolate and ice cream and other things, but there's definitely products that are bad for you. But if you kind of move away from a handful of products that are really bad for you, it's not like most food companies don't try to make healthier products. They do. They try to make lower salt versions or healthier versions of food products. McDonald's has had salad on its menu for like 20 years. And Americans just don't buy it. Americans don't buy those products. If something says healthier or good for you, sales go down. Again, McDonald's has salad on the menu. People don't walk into McDonald's to get the salad. So I think you're right, but we can't entirely blame the private sector, because when they do try to make healthier options, most Americans don't actually buy them. And the other crazy thing is, whenever you have politicians, this is something I've noticed. I hope you notice it looking forward. If you ever see a politician during a campaign doing or interacting anything with food, they're always getting the worst possible unhealthiest option, because they're trying to look like the common man. They're going to be eating deep fried butter or chicken fried steak or something that's like the worst thing out there because they want to look like the comments. So there's also kind of these cultural issues about unhealthy eating versus healthy eating. But there are solutions, and that's where I'll end, is everything I outlined changes the economics of healthy eating. If you have healthcare paying for produce, if you have, we didn't talk about SNAP, but if you have SNAP incentivizing healthier purchases, if you have procurement of hospitals and other businesses prioritizing healthier foods, if you have school meals with healthier standards, if you start putting into place policies to buy healthier foods, you change the calculus and you change the incentives from farm all the way to retailers. And then when the customer goes in, the healthier products are going to be the ones that are up there because those are the ones that are supported by the SNAP program or supported by the Medicare or the Medicaid program. And the supermarket knows that and can make more of a profit on it. So we have to think about the dollars, and we have to make the healthy food more affordable and more profitable, and the unhealthy food less affordable and less profitable. And most of the things I outlined will have some of those effects.
All right. Then we have time for one more question.
Not a question. Dr. Musafarian, this is Sonia Hauser. I just want to, on behalf of Russell Sage, thank you for being with us today. And I have to say, I'm a very proud Friedman School alum right now. It was very inspirational. Thank you.
Wonderful. Well, our alumni are our best product. The most amazing thing that we produce is our alumni. So, really honored to be invited. Thank you.
All right. Round of applause for Dr. Musafarian. Thank you for the in-depth conversation and for answering our questions. All right. And now I want to move on to our interactive panel discussion, as I was talking about earlier. Everyone that is in the panel sitting up front here, I want to have you guys move up one by one as I call your names up. Let's have Sonia Hauser. A round of applause for her, Associate Professor and Chair of the Russell Sage College Nutrition Science Department. Then I have Ellie Wilson coming up as well, Manager of Lifestyles and Wellness at Price Chopper Supermarkets and Market 32. And then Alex Almadine coming up as well, the Special Initiatives Manager for the Food Pantries for the Capital District. Allison Durand, as we heard from earlier, Community Wellness Advocate at CDPHP. Amy Wall, Diabetes and Nutrition Services Program Leader at Hudson Headwaters Health Network. Josh Stefani, Food and Farm Hub Manager at Comfort Food Community. And last but not least, of course, Sarah Salvatore with us, Assistant Professor in the Russell Sage College Physical Therapy Department. And now I want to open it up to the panel discussion. You guys will each have about 5 minutes to talk. Sonia, you'll start.
Okay. First, I meant earlier to welcome our viewers on the live stream. I forgot to mention that we have hundreds of students and alumni and friends joining us on the live stream, so thank you for being with us as well. And I just want to say, too, for our students who are here, so Dr. Musafarian's words were, nutrition is the single biggest challenge and opportunity in our nation. So I hope that confirms your choice of major. We have a lot of work to do. So we got a great overview of the national perspective and the White House conference from Dr. Musafarian. So as part of this event, I really wanted to give an opportunity for the local initiatives under this sort of food as medicine umbrella, the local innovations, and the local innovators. So that's who we've invited here to join us today. So we're going to speak to each of the 5 pillars, and there's a lot more we could say, and honestly this panel could be a whole lot bigger, but the stage limited us. So I will just start by briefly highlighting one of our newest projects in the nutrition department at Russell Sage, which is our next slide, please. Our culinary medicine initiative. So this is in collaboration with Albany Medical College and Dr. Beth Dolinger, who asked the series of really probing questions, thank you. So she has been leading the way on this culinary medicine initiative. We just wrapped up the pilot phase actually on Monday. And we've been using the Nutrition Science Lab, and we've had AMC medical students working with our graduate nutrition students and dietetic interns. And over the course of the semester, they've developed 7 culinary medicine modules with a focus on pregnancy nutrition. So this is really exciting, and we're planning to implement these modules in the community with patients starting in the fall. So we're very excited about the potential of this collaboration, and we'll be recruiting a new cohort in August. So that's very exciting. So that's all I'm going to say. I'm going to yield the rest of my time to Ellie, because I think she has a few things to say, maybe.
Yeah, this has been a really great opportunity, and one of the my roles and how I came to be in that role at Price Chopper. I'm going to refer to the slide that Dr. Mozaffarian put up, where it showed the fact that grocery stores are actually increasing nutrition resources or nutrition capacity. And in 2010, well, I started at Price Chopper in 2007. By the time 2010, 2011, there was about 40 dietitians across the country in retailers when I started. And starting around 2010, 2011, we got that bumped up to almost 2,000. So there are a lot of system changes going on at those levels and in companies to move this needle. And I'm pretty happy to have been part of that. Another thing I wanted to make sure that we talked about today is the types of food and nutrition services and care, because in care and in health over the years, and I think colleagues that have been in practice would agree that the term nutrition is very fuzzy. And it's particularly fuzzy when you talk about care and when people conflate nutrition information, nutrition education, and medical nutrition treatment. And we can't have that anymore. As part of this strategy and as part of our time now, we must clarify what that information is, make sure everyone delivering it really is confident and has good resources, goes to what he spoke about with accreditation, et cetera, but also that we are ensuring we have access to the profession, the dietitian, that is able to work and educate in every single one of those levels, from food formulation, from even supporting farming education, et cetera. So in the Academy of Nutrition's Retail Nutrition Certification, I've had the privilege of being an author twice. And in our first module for the current certification, we have this slide, types of food and nutrition services that people may access through grocery. And really the primary ones that are available are food information, meaning food labels, and or shelf tag programs, such as the one we have at Price Chopper, which is Know Your Colors, or you may also be familiar with Hannaford's Guiding Stars, very much at the shelf and store level to help interpret nutrition information on products. And actually those systems push the formulation of products into better standards, because now there's a big rating or scale on that item. So we have the Know Your Colors program at Price Chopper, and it's been such a privilege to be able to offer this. Those are information, education, population health level, that bottom tier of the pyramid that Dr. Mozaffarian had up. But it's an opportunity for us to learn, how do we help people seek and find food that will work for them, that fits their lifestyles, that fits their culture, and that fits all of those other elements of communication, such as literacy and language. So it's been a huge privilege to be part of this, and that also helps us connect the dots to our community partners. So I'm going to pass this now to Alex.
Great. Thanks, Ellie. Also, thank you for having me here. I am one of the few in this room that is not a registered dietitian, but I feel really honored to see a lot of our interns in the crowd that have been placed at the food pantry, so it's really exciting to see all your faces. So I represent a couple different organizations. I work for the Food Pantries for the Capital District, which is a coalition of 70+ food pantries in the Capital Region. We serve Schenectady, Rensselaer, Albany, and Saratoga County. And I also represent the Alliance for the Hunger-Free New York, which is our leg, arm, whatever you want to call it, that represents statewide initiatives. And so in-house, we run 2 food as medicine programs. We run a medically tailored grocery model, and we run a medically tailored prepared meals model. Both are in partnership with 2 referral partners, Saratoga Hospital and Whitney Young Medical Center. Our individuals are enrolled for 6 months at a time, and our grocery model serves the individual and their household weekly. Our meal model serves 2 meals a day, 7 days a week, also serving the household. But we will hear from the rest of the panel a lot of different food as medicine models represented in our area, and so I really would like to focus on the statewide initiatives that we are working on. So in 2022, the New York Health Foundation granted us a grant to build a committee, a steering committee, a coalition of stakeholders in New York State to come up with a plan for how sustainable funding, specifically Medicaid First, will be implemented in executing food as medicine services. So we learned a little bit about that earlier. New York is one of those early adopter states down at the bottom that has worked on the 1115 waiver. And so for those of us that don't know what the 1115 waiver is, it is a set budget that CMS, Center for Medicaid Services, grants each state. So it's about $13.5 billion for New York State. And we have gone through the commentary period of how we are recommending New York State spend those funds. So the food pantries has put, and you can go to the next slide. Yeah, thank you. So New York State, or the food pantries along with a bunch of stakeholders put together recommendations right off the bat. And where we're at right now is we have formed a coalition across New York State, wide diverse of stakeholders represented, a lot of them in this room and on this panel with me, from all sectors, from agricultural to providers to individuals in the community that have lived experience and expertise, to our payers as well. And we have grouped together a coalition as well as 5 work groups. The work groups are sustainable funding pathways, the intervention models, right? So we had seen a pyramid model. That is what FIMIC, the national model, uses, as well as Massachusetts. But that is not what New York State is using right now, because we would like to add some intervention models into that visualization. So the intervention models is a work group, education of the medical community is a work group, outreach and education on how do we disseminate the information around food as medicine is a work group. And I am forgetting the last one, but it will come to me. And so, yeah, evaluation and research. Thank you, Allison. And so that's our last work group. And we meet monthly, and we are putting together the service menu and the ways that Medicaid, the approved budget will be spent and how to execute that into sustainable food as medicine services for those that are eligible. And we're hoping that we don't stop there. Medicaid is just the starting point, but what comes next and what comes beyond that, so that food as medicine services are accessible to all. And so if you are interested, there are lots of opportunities to be interested in that and get involved in that, but we are in a really good spot in New York State. And I think we are a part of other states and learning from other states, specifically Massachusetts and California, that have been doing this for a little bit. And so we can learn from their mistakes and make New York a little bit better. I'll pass it to Allison.
Thanks. I'm on the Food as Medicine Committee that Alex just mentioned, and I want to just give you some credit and the food pantries for the tremendous effort that it was to get all of the right people at the table to have those discussions, because dietitians are one pillar of that, but not the only, as we've learned throughout today's presentation. And I guess I'll use my 5 minutes, what time is it, because I can be long-winded, to highlight some of the CDPHP programs that are in place for our members in the Capital Region. For our Medicaid membership, so that's our income-based plan, we have a healthy home-delivered meal option. So that's kind of the highest level of the pyramid discussed in the presentation, where someone has a reason or a acute inability to prepare meals from food, we will send them 2 weeks worth of pre-made meals, either after a discharge or after some sort of acute injury, to kind of make sure that nutrition is one thing they don't have to worry about while they're focusing on whatever this other priority is, be it a surgery, an arm sling, etc. The other we have is our medically tailored food package program. That is the second level of the pyramid previously shown. And the engagement there is with coaching from a registered dietitian. And this is my opus, because as a dietitian, I'm constantly trying to figure out how we can plug dietitians into various programs and really advance the profession. So this program is anybody with a chronic condition who's on our Medicaid plan and is interested in the educational component to better manage said condition can engage with a registered dietitian up to twice. It's honestly unlimited, but we prefer up to twice a month for 3 months minimum. That dietitian then turns around and orders groceries for the participant to complement the education they received. So citing my previous nutrition counseling years, if I explain to you the difference between wheat bread, 17 million grain bread, ancient grain bread, and then whole wheat bread, I can do that education and then order you whole wheat bread, which is lovely. We additionally have, in partnership with Josh, who's 2 down the line here, a farmers market voucher program. So I love this program too, because it's keeping dollars in our local community, and it's also putting money into the pockets of the farmers of New York. So CDPHP funds a certain amount of dollars or vouchers. We wanted them to be tokens, and then the pandemic happened, so they kind of became disposable, but I digress. For folks to turn up to a farmer's market, specifically we partner with the Glens Falls and the Saratoga farmers markets because we're kind of trying to hit that rural community who I think often gets left out of conversations related to food security. Members can present to the market, meet with Comfort Food Community, who is a lovely grassroots organization I hope Josh will tell you more about, receive some vouchers, the amount varies, and then turn around and use the vouchers to purchase healthy food from the farmers at the farmer's market. That program has received resounding applause from the community. People love that program, would love to be on it for the rest of time. We've seen it grow exponentially since I started at CDPHP, and it was founded in 2020. We also support the Center for Medicaid and Medicare's program. So this is federal Medicaids in lieu of service medically tailored meals. That program, I'll be honest, and this is one of my platforms that I won't get into because I don't have enough time, is a little complicated, but the point of it is to provide meals to folks who are either a high utilizer of healthcare or are receiving support services to help them make meals. So the thought is if we can give them pre-made meals, maybe we can take away the amount of man hours required for them to use for food prep. That is another program we offer, and then we have a variety of Medicare offerings for our seniors and disabled eligible members. So Medicare is 65 plus, and then if you have a qualifying diagnosis. Similar to the programs I just described, we have a post-discharge meal program where if you go to the hospital, so say your Nana breaks her hip and she comes out of the hospital and she's not sure how she's gonna have food because she has a broken hip that she just had surgery on, we'll send automatically, just based upon the inpatient stay, 2 weeks worth of meals to her so that her food needs are taken care of. There's also a chronic condition program. So that's a 6-month duration, similar to the medically tailored food package. It's food plus engagement with a registered dietitian for education. So I'll end my rant there. I think I did pretty well on time, but those are the programs that CDPHP offers. And additionally, I should say, we're a not-for-profit health insurance company, which I think really defines us from some of our competitors who are for-profit. I've worked for a for-profit insurer, and it is an entirely different culture. And it's one that I hope other people see and adapt. We are trying to prove that ROI value, which is the return on investment, that economical piece that our presenter spoke to, because that's really what everyone cares about, is where's the savings? So we're investing in these programs, hoping to connect our members to them, hoping to support the organizations who run them, and then also hoping people are watching the successes and doing it themselves too. Amy.
Great. Well, at Hudson Headwaters, we do offer CDPHP to our employees for health insurance, so yay. So I work at Hudson Headwaters, and for those of you who don't know, we're a primary care network in the North Country that spans from Monroe, New York, all the way up to Plattsburgh and Champlain. So as you can see on the slide, our food as medicine programming kind of encompasses multiple areas. So we have our food pharmacy program. That program I'll be briefly mentioning a lot more while I talk. We also have our pop-up farm stand for patients, our employee wellness programming that we've started, and our Mediterranean bag program for patients as well. But like I said, food pharmacy is what I'll mainly be talking about today. So our food pharmacy program, it falls under our population health department at Hudson Headwaters, and it's a 6-month program. Patients that have prediabetes, diabetes, BMI over 30, and food insecurity is the population that we focus on. So basically, patients, it's a provider-driven program. So a provider drops a referral to our food pharmacy team, the coordinator reaches out and she talks to the patients, kind of assesses to see if they're appropriate for the program. And then from there, once they're enrolled, we do a pre and a post survey. The survey contains information about their culinary cooking skills, their eating habits, there's some food insecurity questions, some fruit and vegetable consumption questions. So that's one way we can kind of gauge improvement and take some of that qualitative data from the program. So a patient, once they're enrolled, they get a fresh produce box sourced from Comfort Food Communities, who Josh will talk about in a second. So we'll talk a little bit more about the sourcing of that. So they get a fresh produce box every other week, and then basically for all the members of their household. And they pick it up either at the health center or they actually get it delivered depending on where they're located. We're also in 6 health center locations, so we've tried to really expand over the years. We started in 2019, and it's kind of taken a different shape as COVID and all of those types of things have happened. So they get the fresh produce box, and then also nutrition is a big piece to our program. So they do get dietitian phone calls. They also receive supportive recipes based on what the produce box includes. We also provide nutrition and diabetes handouts, and we also provide some food, cooking, and culinary handouts as well. And what we're looking at to do here is to really get that food insecurity piece and also provide more fresh food accessibility to those rural communities. So Hudson Headwaters, we have a lot of rural community areas where there's food deserts, and a lot of people end up shopping at the local Stewart shop or the Dollar General or Family Dollar. So really trying to get into those communities a little bit more and provide some more fresh food. Some areas where I think we'd like to expand a little more in the future, we're planning on doing some virtual classes with our group, which is starting next week. And we're looking hopefully to partner with more community-based organizations to do some cooking classes. Because like where the medically tailored meals comes into play, where the food's already prepared, we find the challenge is that these patients, they get the food, but they might not have really cooked much fresh fruits or vegetables, so that having that culinary and cooking piece would be really important for our program as well. So I'll hand it over to Josh to talk about the food.
Yeah, thank you, Amy and Allison, for the shout out, I guess. So the piece that I want to bring to this too with Comfort Food Community, so we're a nonprofit based up in Washington County, so just to the north of here, but we serve Washington, Warren, and Saratoga counties. I also do a lot of work with the Adirondack region, looking at the big question of rural food insecurity, which what we have worked through with the food pharmacy program is really trying to address what that means, not only for the clients, but I would like to say I speak to where that food comes from, because when we talk about food access, when we talk about food as medicine, we kind of forget where that food is coming from and that connection to the farmer. And so the beauty, if I can be biased in my description of the food pharmacy program, is that almost entirely of that CSA box is made up of products that are sourced locally, so sourced within those three counties. That being said, oranges, not local, not yet. Climate change is real, but maybe one day we'll get there. But the beauty of that is there is a connection between the health center in Glens Falls to the farmer, and that for individuals who are part of this program, low resource individuals, financially struggling at times, that they don't necessarily have that finance, and this could be speaking to the program with CDPHP too, is accessing that local product, and the farmer is getting a fair compensation for that product as well. And so that's a really key component of our food as medicine model for both programs, but also what we advocate in terms of emergency feeding programs. So we're primarily, that is our realm. So thinking about how someone who attends a food pantry can not only shop with dignity, lack of vulnerability, but access fresh local product that came from farmers in Schaghticoke or Saratoga Springs, right? And that's a key component to any nutrition. And I'll echo Alex here, because I'm not a nutritionist or a dietitian. I come from farming and agriculture, so I'll talk about farmers and food more than anything. So I'll turn it over to Sarah.
Thank you. So I'm happy to be here representing the Russell Sage Physical Therapy Department, and I'm talking about a little bit of a different topic. As a physical therapist, we work closely with registered dietitians, and I think we're a really integral part of the care team in managing chronic disease. So I'm here to tell you how we can, as healthcare providers and community members, support physical activity for all. So the most recent data from the Department of Health and Human Services found that 80% of Americans do not meet minimum recommendations for physical activity. So obviously, physical activity is a huge issue that we also need to work on. We can really look at it in 3 ways, and I'm just going to tell you about a few of them, and I'm sure there's many more, but we'll talk about a couple of them today. So the first is individual education. So as we're working with our patients and as we're talking to our community members, friends, and family, we need to remember that any activity counts. Gone are the days where we used to say you had to exercise for 10 minutes to make it count. It now counts if you do any sort of activity forever. We found that people who are less sedentary are healthier overall. So anytime we can get people moving, that's a positive thing. I've also included a website. I don't see too many people taking notes, but I'm sure I can get this to you after. But if you want to check out choosept.com/prevention and wellness, the American Physical Therapy Association has actually made handouts that providers can give to their patients that give them really quick and easy ways to implement more activity in their daily lives. The next way we can work with our patients and also volunteer is with community programs. So there's actually a number of free or low-cost exercise programs available to community members in this area, and these are just a few. The first is Silver Sneakers, and that's an exercise class that's for older adults, ages 65 and older, who have Medicare plans, and actually most Medicare insurance providers will cover this for their patients. So if cost is an issue, older adults can access exercise classes that are age-appropriate, really fun, give them a social outlet at a number of different sites in the community. The next one is Girls on the Run. So if anyone's familiar with Girls on the Run, this is for girls ages, grades I should say, 3 to 8, and it aims to empower girls and teach them teamwork and community around a fun physical activity like running. I know some people do not think running is fun, I do, but it's a really great organization, and they're always looking for volunteers for coaches, but you can also refer girls that might be in your life to this as a great way to learn about physical activity. The last one is the YMCA. So the YMCA of the Capital District is a wonderful resource. They have a lot of community chronic disease management programs. They have scholarships available for people who have financial need. There's childcare. There's a number of different types of classes for people who have mobility impairments and different interests. It's really wonderful. So I encourage you to check it out and tell your patients to check it out if they're looking for a place where they can exercise. The last way that we can work on physical activity for all is through legislative advocacy, and this is huge. We have really good research that shows that communities that have really good, safe walking paths, road crossings, bike lanes, bike share programs, they have individuals who exercise more. So we need to provide these things for our patients and for our community members, and a lot of times that's going to be through advocating through our local government. We can also work on advocacy through health insurance reimbursement. So while we have some really great insurers in this area that will cover physical activity services, in general, that is not something nationwide that happens, and that's something that people need. You know, we know financial access to physical activity is a real barrier for a lot of people, and insurance reimbursement can help defray that cost and provide people with that opportunity. And that's all I have.
Thank you guys for all of your knowledge. Now I want to open up the floor to you guys. Does anyone have any questions for any of our panelists here? We've about the next 20 minutes, I would say. Here. Don't apologize. Questions are good.
I think this is probably for Amy and maybe for Alex. You have this food pharmacy program, and your patient, the metrics you're using to enroll patients are BMI, prediabetes, and diabetes. So I assume you're using the hemoglobin A1Cs. I don't know how long you've been running it. What are those the metrics you're using to follow those patients? And what have been your challenges in enrolling them? And the reason I ask is that we started a program like that back in Elmira probably a year and a half ago, and our medical students actually deliver the groceries. So that the medical students are intimately involved with each one of these families. But we've had a real struggle enrolling patients. And I'm wondering how you overcame those barriers and what you're using to monitor or measure what your outcomes are and how your outcomes have been.
Right, do you want me to?
Sure.
Yeah, so when we first started the program in 2019, we actually did more of a population health way of getting patients. So we looked at lists and we picked patients with A1C over 9, and there was a lot of outreach from our community coordinator, who's actually in the audience right now, and we reached out to those patients to get them enrolled, numerous invitations, that type of thing. Now it's morphed into doing a lot more provider education about the importance of the food pharmacy program and kind of just being in their face about it more. And so we've gotten a lot more provider referrals that way. So we do, doctors refer, we have nurse practitioners, PAs, I myself as a dietitian refer, and we have a diabetes educator as well that sends referrals. So now we're at the point where it is referral based, and care managers can also refer the patients to the program. So as far as, you know, tracking their biometrics, we use A1C, we use BMI, and we use blood pressure. So they get their A1C drawn. You know, we take, if they don't have one drawn already, we'd make sure it's drawn before they start the program. And then after the program, we try to get an A1C done, you know, within that 3-month time period. And we do see favorable results, the downward trend of the A1C. I'd say on average about 75% of our patients lower their A1Cs, and it ranges from about, in that group, it's about like 0.5 to 2 point reduction. So it's a pretty good reduction. Weight is a little more tricky, so average weight loss is 2 to 5 pounds. However, we have had people, we've caught them at the right time where they're motivated to lose the weight and really focusing on the nutrition and activity piece. And we've seen like a 20-pound or 50-pound weight loss in some of those patients as well. Did that answer your question? Yeah.
Yeah, so ours is similar in the sense that we have a bunch of providers, right? So we utilize the Food Pantries Coalition network for servicing those individuals. So not all of our providers are housed in a hospital. We do have 2 food pharmacies that we utilize, but we do access a wider network. And so for us, it's a funding issue. There are plenty of people that could benefit from this program, and we have the means to serve them. It's about who's paying to serve them. And so that's where a lot of the statewide work comes in, because you are looking at a more sustainable in the sense of, you know, 1-year grants or philanthropically funded programs. You know, a 5-year 1115 waiver is not the most sustainable, but it's better. And so I think for us, we have a referral partner and a champion at each one of our referral centers. It does start with just pulling the data in the system and then going and doing outreach and saying this is what the program entails, because there has to be ownership and choice in participating in this program, right? So if they don't want to participate, then that's totally fine. We're not going to make anyone do it. There are plenty of people out there that are eligible for it that want to participate. And so the outreach and education component is super critical, but serving them and figuring out how to get them into the system, that comes afterwards, and there's an abundance of people that are eligible. So we never have a lack of interest for the programs, but we do similarly look at pre and post biometric data. It's different because we are not a healthcare entity, and so you move into HIPAA and you move into being a covered entity and all of that. The infrastructure is not built in our system, right? So we talk about, look at this panel. This is a panel of innovators. This is not your norm. We unfortunately do not represent the way our world works. We are hoping to get there, but there's a lot of infrastructure and cultural norms and progress that we need to make before that happens.
Does anyone, you have a question? Nothing wrong with that.
So I guess this is just for everyone on the panel, more just wanting to pick your brain. So I work for PACE. Have you guys heard of a PACE program before? Program All-Inclusive Care for the Elderly, and we also have a food as medicine model as well. I love PACE because our model focuses on helping participants by taking care of their social determinants of health, and our programs alleviate, like the funds to get these healthy foods and so on. I guess I wanted to pick your brain about it because our food as medicine programs, we work with local food pantries and coordinate with home delivered meal programs because without food, there is no nutrition. So that's one of the first things that we ask participants. I'm wondering if you ever, sorry, not saying this correctly. I'm curious to know on about advocacy efforts to tackle the root cause of food and nutrition security. Like what we do is excellent, but this is just me personally. I still feel like it's a Band-Aid. Whereas I really feel as dietitians, as people in this field, really need to look at this from a systems lens and look at the policy level of it. Like this doesn't have to happen. The root cause of food insecurity, I think we should, advocate for increased minimum wage, affordable housing, affordable transportation, and I wrote one more else down. More affordable universal health care, and so on, because a lot of people, aren't able to get these amazing services that we offer because their other social determinants of health are not taken care of. So I wanted to pick your brain about it. I feel that not only we should continue to do what we're doing, but really advocate to our local, state, and federal government to, hey, if we really want to fix these issues, we got to look at these other social determinants of health.
So I think I can offer some comments on that. The New York State in particular has a Bureau of Social Determinants, which is part of what's driving the capacity for access to food and medicine programs and reimbursement. And that's part of, kind of the public-private partnership initiative that is the only way this is going to work. And you're not wrong, but if you look at it from the lens of who's here, we have the biggest slice of the pie in this equation, right? So I think that it is really about looking at, what your personal effort is in supporting advocacy. I'm part of the coordinating council for the New York State Academy of Nutrition. There's probably 25 people working in New York State policy through that organization that's trying to lift up 5,000 dietitians. We need voices, energy, action, and we've never had a better time. We've never had a better tailwind than all of the White House initiatives, et cetera. This is almost generational. This same thing was what happened in the 30s and how dietitians helped move and shape nutrition policy in the country, but then got kind of moved a little bit aside, I think, as more medicine innovations came forward. So now's the opportunity for us to bring that all back. And I'm very grateful that Dr. Mozaffarian made note of the fact that dietitians are actually named in the strategy. But the rest of that equation is, and this is going to impact every student here, everyone who's actively practicing right now. The rest of that equation is you have to get to the table with that advocacy, because we know that there's been a real challenge with that. On average, 5% of dietitians respond to federal advocacy outreach. If you don't show up, it's not important. So that is how we move this needle, and I do this with the internship here. We talk to policymakers all the time, and they want to hear from us. So, you know, the more we advocate, educate, and just reach out and work together, the more opportunity we have to get to our giant piece of this pie and make it work that much better for people. So thank you for letting me offer that.
Thank you.
And yeah, no. Go ahead. You piggyback and then I'll piggyback.
Okay. And so I also think that we have more voice than those that we are serving and participating with. And so it is really important that what we do is community informed, and those that we are implementing these programs to have a voice at the table, and their voices are amplified. Because we can sit here, we can be innovative, and we can think through all of these wonderful things, but then at the end of the day, if nobody utilizes those services, then we cannot make any change. And so it's really important that as you all go out into the community and work one-on-one with patients, that you are listening to their struggles, right? Because their struggles aren't going to be individual, right? They're systemic issues that we see from patient to patient. And that is the voice that you have to bring to legislation. And that is how policy gets made, so that the changes that we propose, the programming and the funding that we're fighting for is actually utilized and executed.
Well, that was kind of a mic drop, but I will add that, you know, history shows us, it's a really great question, that, you know, big problems are not solved unless change happens at the policy level. But how do you change policy? You do small things, you do small interventions, you collaborate with, you know, different stakeholders, right? And none of those things feel big, and they're hard, usually, right? So students who worked on my summer meals programs, right? You're in a park, you're at a summer meal program, you're collecting data, it feels really small, but that collective effort, right, leads to building a database, right? So we do things, we try them, we test them, we evaluate them, we build an evidence base, and that's what drives policy. So each little thing that you're doing, you know, you might be frustrated, right? I hear that you're frustrated, right? I think we all share that at times, but the collective effort is what drives things, and I think we're at a pivotal moment right now where there is this momentum and this collective voice on this issue, and so I'm excited to see what will come. So, yeah, great question.
It's a scale, so the food insecurity problems in Albany are going to be very different than Ticonderoga. I mean, thinking about how we approach, you know, we talk about a Band-Aid fix to a larger systemic issue, it's not a one-size-fits-all. And I think it's how that local-driven, and when we're talking about influencing policy, it's great that these federal initiatives are happening. It's great that the state work that is being done, but it's also happening at a county level, a city level. You look at Clinton County, all the way at the border, Plattsburgh, right? Food Policy Council that's driving initiatives around food as health, right? That was designed by their Department of Health and I forget, I'm not up in Clinton County that often, but they have a very specific locally driven platform. They have collections of networks that are happening. I mean, I speak regularly for 16 other agencies representing 14, one of the other agencies is in the House today, but that are trying to solve these problems on their, not only their local level, right, I speak for 3 counties usually, but also on the regional, how we can share information, how we can collaborate. In an ideal world, my organization does not exist. And Alex would probably say the same thing, that we're fighting a system to essentially make ourselves without a job, which is fine, and that's the great thing, but it's more than a one-size-fits-all Band-Aid. And transportation, and I lived in Troy for about 5 years. Transportation here is very different than transportation in Washington County. And so our methods have to match that madness of each of those localities.
I feel very compelled to share just one quick thing from your Food Justice Summit that was up north, that was shared by the panel there that really resonated with me, and I see some attendees in the crowd. The example was, right, give a man a fish and he eats for a day, teach them to fish and they eat for their life. But it's like, what if they don't have a ride to the pond to get the fish? What if they go to the pond and there's no fish? What if they go to the pond and there's fish, but they're all poisoned and they're not healthy fish? So that, I feel, was the example given to explain the social determinants of health, which are these ancillary barriers in the way of people who want to be healthy that they don't have a lot of control over.
Interesting. Question over here.
Hi, I'm Jolene Caricio, and I'm on the nursing faculty here, and we teach community health. That's my area. As a nurse, what do you do about the patients who don't want to get healthy, or they're third generation that grew up on processed garbage food, and that's all they know and that's all that they think, or the media that then promotes, just take Ozempic and you'll get the weight off, or have bariatric surgery and it's instantly cured. You know, modern medicine, there's a pill for that. I was just recently at a school, a little girl, probably 8 years old, little cute little thing comes into the nurse's office. She was newly diagnosed as a type 1 diabetic. They have to do a finger stick, and I go, wait a minute, why is she getting a finger stick and an insulin? There's Dexcom, you know. The mother doesn't want to deal with that. Okay, she's one of 8 children. Her blood sugar was 400 in the morning, and so they had to call home. Oh, she was at grandma's this morning and had cookies for breakfast. She sat down. This little girl is so smart, and this will be her saving grace. She calculated her carbohydrates for lunch. 99 carbohydrates. She opens up her lunch box. It was white bread with peanut butter and fluff. I did not know Reese's Pieces makes cupcakes. A 2-pack of Reese's Pieces cupcakes, a Jell-O chocolate and vanilla pudding. I'm now going into shock. And a container of chocolate milk. That was lunch. But mom has 8 children. She just lines up the same thing, takes out of the boxes. And the school nurse said they're working with the endocrinologist on this because they can't report. I mean, this is almost child abuse, but they can't report it. This girl has an older sister who's probably in 4th grade who's really going to learn this and help her. But what do you do about this is what we see in the hospitals. You know, I don't have to do this. And they're back 5 days later or 10 days later. Where do you get the psych piece to re-educate? All this, we teach our nursing students about all of these resources. And I say, you might get through to one person, but that's a systemic problem that's now 3 generations in. I mean, I grew up on a farm in Illinois. We raised our own food. I still do. But what do you do about that?
We have a clock here with 7 minutes on it. I'm like, we need 30 minutes to answer this question.
Yeah. I mean, I think I'll go really quick and then whoever else wants to jump in. But I think it's in your question, it's a systemic issue, right? So again, this might be an unpopular opinion because I am not a dietitian, but for me, you might be able to reach that individual and talk to that individual, but she's not supported with resources to make those changes. And so for me, that's in the national school lunch policy, making sure that it's free for all students. So every student that walks in gets it. It's not just, 20% of the population or 30% of the population, it's everyone. And now that child has access to a quality lunch. And then it's creating a system where, when you go to a corner store, there actually is healthier options. When you go into a lower income area, you're not bombarded by fast food marketing. It is a systemic thing because you're going to have early adapters, you're going to have those that are willing to make this change before others, and then you're going to have those people that are straggling along. And so those people really the change only happens when the rest of the environment has changed. Yeah.
I would offer that one of the elements of that too is that their lives are already so hard. Perpetually hair on fire is the way I've thought of it. I mean, I'm from Schenectady. We have over 2,000 food insecure children. And when everything is an emergency, you lose the ability to see the emergency, right? So it is, again, it's part of our system challenges. I think there's real encouragement in the fact that we have more behavioral health capacity being built into healthcare systems and hopefully be able to partner on things along that line. But, as we come into these last few minutes of our program today, are you okay with me kind of rounding up a bit? Because I have too much to say. So the opportunity is, one, the collaboration, the interprofessional collaboration. We don't have to be dietitians to help people understand that we all need to eat more produce, and those numbers today clearly showed the resources aren't necessarily the only problem there, right? So there's opportunity there. There's opportunity, I would love to be a student right now.
Same.
I am jealous. Really jealous, so I'm going to be around for far longer than I should be. So, but the opportunity here, and I term this food and medicine, that pillar of the White House that says that nutrition should be part of health. Nutrition is still not there yet, right? So we're still carved out. Again, this is the moment, this is this pivotal moment for dietitians to really bring all of the power of your training and capacity and diversity and your adaptability. Dietitians work from farm to movie, there's so much opportunity in this space, right? So what's going on here that will help these changes that dietitians should be more involved in? Informatics, nutrition and food data. I live in that, and it's not a pretty place. We have a lot of work to do. Communications, right? And that also goes to that interprofessional education. I'm actually going to ask why the Academy isn't one of the partners in that medical school discussion about training, because I don't think there's any more qualified professional that sees patients in all of their times and places of life where we could bring that lived experience together. Yeah, this is a 5-lane highway that's already built. We talked about this, and we just have to really use it, right? We are in on-ramp mode, but we are all here. Now's the time for everybody to get on this highway. For those of you who are New York State, what we can speak to most here, you need to call your legislators. You need your parents, your cousins, your neighbors to call their legislators, because what this changes is quality of life, all of the aims of improving healthcare, improved patient experience, including that mom and her 8 kids, right? I mean, the opportunity here is to just shift this paradigm and improve the dynamic. And it's all through the ability of and the flexibility of RDN training and capacity to collaborate with nursing and pharmacy. And you know, I have in one database 1.6 million food items. So I'm really not confident that my physician in the 8-minute, and it's not their fault too, that's a system issue, right? But in that 8 minutes, that they're really gonna be able to move my information level forward that much is why I asked about how will systems really help elevate and capacitate the RDN and the dietitians and nutrition professionals, because we've been out of this system for too long and it is our moment. And it's the dietitians that have brought the outcome numbers. There's no other entity that has 25 to 50% changes in costs and outcomes other than food and medicine programs. So it's our game now. It's time. It's our highway. Even this is an opportunity to protect the public and ensure that while we are positioning nutrition and food for health, that we are not medicalizing it to the extent that people are judged for what they eat, judged for having birthday cake.
That's
you know,
yeah. That
so that would be that's really, trying to be as global as I could here, but that was our opportunity to try to wrap up what we brought today and everything that's happening here. So many models and so many opportunities to learn more and be engaged.
Yeah, for that example, I realize we're almost out of time, first of all, is non-judgment. So like, sure, she's feeding 8 kids Reese's, whatever you describe sounds delicious. I'm not gonna lie to you. So non-judgment. Also just reality of how far you're gonna move the needle for someone. That was like the crash course I got when I left school and was like, I'm a dietitian now. Is I'm like, everyone's gonna eat plants. And it's like, if you're convincing a person to consume 100% apple juice instead of a candy, that's progress. And so like focusing on small realistic changes in that specific example and on a broader comment, wouldn't it be nice if the healthy, nutritious foods were as convenient and affordable as the garbage food you described in that lunchbox? Like, that'd be the goal, because then it wouldn't be so difficult to find and select them.
And that is where dietitians are in food and food industry now, is in that formulation opportunity, in that information and formulation opportunity, because we got almost no information in the past. So
there were a lot of other hands. We're out of time, but we have lots of food in the back. I encourage you all to stay and chat and network, so feel free to help yourselves. And thank you all for coming.
A round of applause for everyone on this panel. Thank you all for your answers and being here. Now, Ellie, is it okay if you can come up and give us a final few words? You ready to, okay, I was making sure. Well, that's it for the panel. Thank you all for joining us. And again, there's snacks in the back. Stay around if you have any questions. So, thank you.